on what is defined as a concussion. Years ago, you needed to either have loss of consciousness or amnesia. Amnesia is a medical term which describes the ability to make memories and to keep memories. So we have some types of amnesia called retrograde amnesia. So an example of that would be you didn't remember what you ate for breakfast before your concussion. You can have amnesia to the event, meaning you don't remember how you sustained your injury. And then you have anterior grader, meaning going forward problems. So you may not remember driving to the clinic or driving to the hospital after your collision. And I personally can speak from my own experience. I don't remember what had happened right up until the point I had my loss of consciousness, and I don't remember really going to the hospital even though it was about 25 minutes away. So some of these memories may not come back, but that's very important because a lot of the treatments that were recommended years ago were based on the degree of amnesia and the degree of loss of consciousness. And as you'll see going forward, those may be older ways of doing it, and that's one of the things that I want to focus on is the treatment needs to really be standardized in the beginning and individualized going forward. So again, just to keep everyone on the same page, you don't need to lose consciousness for a concussion. So, as I talked earlier, the brain is made up of these neurons as the main powerhouse thinking cell of the body, and the neurons control a lot of things. The neurons can control our muscles, they can control our memories, they can control our thoughts, and these cells normally have salts inside that are potassium. And when you get injured, these potassium salts that are normally inside the cell end up leaving the cell. And when that happens, salts such as calcium that are outside the cell suddenly go inside it. And the cell doesn't like that much, and the cell therefore becomes injured, and the cell doesn't communicate as well to the connecting neuron. And because of that problem in communication, you get all these symptoms that can evolve from that. And with regards to the recovery, even just on a cellular level, it can take days to even weeks for the cells on their own to return to their normal metabolic condition. So how commonly does this occur? We know that concussion, it's been estimated that there's over 3.8 million concussions occurring annually in North America. So that's pediatric and adult that occur. We know in the United States over 700,000 ED visits occur annually for pediatric concussion. And we know further, based on some work done by Alison McPherson, who's an analyst and researcher through the database organization ISIS, based out of Toronto, that they found that the incidence of pediatric visits for concussion for both clinics and for emergency doubled between 2003 and 2010. We're also going to be able to repeat this work and look on this further to look beyond 2010, because quite a landmark media event occurred in the first month of 2011, and that was Sidney Crosby. And if you look at how many, anecdotally, how many visits more we've had in our emergency departments following that high media profile cases of both Mr. Crosby as well as the tragic cases of some high profile athletes who have committed suicide and some other long-term sequelae of their concussions, my hypothesis is that the numbers have gone up even more beyond 2010. Further, the issue is still one in which a lot of things have to happen for us to know that the child's come to us. So first thing that has to happen is the child themselves or the coach needs to suspect that the injury has occurred. And if that doesn't happen, that child can continue playing. And when that happens, you can have tragic consequences. There was a recent inquest that many of you have been familiar with. It's been on the frequently on the news, talking about a tragic case of a young teenage girl who was Ottawa high school player, captain of her rugby team, who sustained a concussion on one day, and then subsequently in a tournament several days later, 2-3 days later, had another head injury in which she then had what's known as second impact syndrome, which is fatal. Second impact syndrome is very rare, but it is one of the most obviously severe consequences of having not fully recovered from a head injury and then sustained a second. So again, step one is recognition that a concussion is potentially suspected. Step two is that coach, the patient, and or the parent recognizing that this is something that requires medical attention. And then step three, the patient and needs to seek actual medical attention. And if all three of those things don't happen, they don't ever show up in our records, so we don't know how many concussions there are. And it is for that reason the Center for Disease Control, based out of the United States, has defined concussion as the silent epidemic, in the sense that there are probably many more that occur that we never even know about. So again, with these changes on the cellular level, a whole cascade of events occurs. I see Phil Fate had plugged in a comment and a cascade in neurometabolic, and that's exactly right. You get this whole cascade. You get a change in the glucose, which is our sugar that our brain needs to utilize for our energy. Axons are the highways of these cells, and they can be very long, up to feet in length, and these axons don't work as well. And it's kind of like if you play the classic game telephone, where I tell you to tell your neighbor something. By the time it makes it all the way around again, the signal may be very different. You can get changes in the blood flow, which is the main thing that causes this second impact syndrome. The brain swelling occurs, and because the brain pressure becomes higher than the body pressure, you can even get it to a degree where the brain doesn't even get any blood. As I talked about, you get these salt shifts, the release of these hormones that can change how the signals are transmitted. And again, although the cellular injuries may last for days or weeks, the symptoms can often last from weeks to months following this event. So again, as I talked about, it's all about a balance of energy, and the energy unit in the brain is ATP. And when you have all these changes, you have a mismatch of supply and demand, and this can result in prolonged symptoms. So it's to the effect of, let's say you have everyone has their smartphone or their laptop computer. If you let your battery of that computer go down, you get the warning, need to recharge, and the operating system kind of shuts down. And what you need to do is, if that system is your brain, you need to let that brain plug in and rest. So all different types of things that affect your brain's use of that energy will impair your healing process. So if you are suddenly discharged from a hospital visit or from a clinic office following a concussion, and you go back and you spend the next few hours playing video games on your home computer, or you're texting with your friends, all of these require energy for your brain to think and for your body to allow its brain to recover. Further, if you suddenly decide, I'm going to go for a run because that helps clear my mind, and your body uses up a bunch of energy by performing a bunch of physical exercise, there's less energy than allowing for your brain to recover further. So that's why we kind of use it, that cell phone battery model is something that we often will describe, in the sense that if that battery is discharged down to barely nothing, you need to plug it in and let it rest. And if you continue to try to use it, your battery will be completely down, and that requires a reboot, and that is when dangerous things can happen. So I'm going to give you a case of a rugby injury. Again, this is not a true case. This is a hypothetical case, but one in which is very similar and representative of many of the cases that I see in the emergency department. To put it into context, we typically see at our Children's Hospital of Eastern Ontario here in Ottawa, we see approximately 900 concussions per year through our tertiary pediatric emergency. That is out of 70,000 cases a year. So about 1 in every 70 cases of kids who come in are for concussion. And when you think about how many days there are in a year, that's about 3 concussion cases we see on average across the whole year per day. So it's a common issue and one that's only becoming more common. Do I think kids are having more concussions? Not necessarily. I think we're getting better at recognizing, and the media attention has led to more awareness and the dangers of concussion that these high-profile cases have led to people seek care more frequently. So I'm going to give you this case, and we'll work through it using the guidelines. So this case is a 15-year-old young girl is playing rugby, and she gets her head struck against her opponent's knee during a tackle. Following this, she was slow to get up, she was unsteady, and she appeared dazed. She was complaining of a headache, she had some difficulty concentrating, she was feeling foggy, and her symptoms, even on the sideline, were worsened by loud noises and bright lights. So, what do we do? Well, one of the things, as Corinne alluded to earlier, was that I was co-chairing and I'm co-chair of one of the ONF groups for the diagnosis and initial management of pediatric concussion. And we wanted to see how do people who are the frontline healthcare providers treat a girl exactly like this. So we had actually sent out a survey to all the primary healthcare providers across Ontario, to nurse practitioners, to nursing groups, to physician's assistants. We also sent it to pediatricians, adult emergency, and pediatric emergency to see a few key things. Do people recognize concussion adequately? How do they manage it? If they manage it, how are they managing it according to what guidelines? And what we found was that there was a fair bit of variation. We found that while people were still pretty good at suspecting concussion, there was still a lot of variation in how people applied various types of treatments, both their recommendations for rest and recommendations for returning to school. So it was something that we felt that we needed a pediatric specific guideline to manage this. Now, many of you may be familiar with different types of guidelines, including the Canadian Pediatric Society has some recommendations. The Zurich consensus statement makes recommendations, but there were always some limitations to these in a few ways. First, some of these were consensus statements, which are a different type of academic endeavor than a guideline. And a consensus statement is when experts all get together in a room and discuss and make the best available based on what they're aware of at the time. Whereas guidelines typically go through a much more rigorous process. Further, many of the guidelines had specific scopes of what they wanted to discuss in their guidelines. So, for example, the Zurich only was discussing sport-based concussions, whereas the literature and research that I've done have shown about 1/3 of all concussions occur in pediatrics due to non-sport injuries. So we wanted to make something a bit more inclusive beyond just sport to those kids who have fallen on the playground, who have slipped on the ice, especially given the winter that we've had this past, and all the other common reasons why kids present to healthcare providers following injuries other than those that occur on the football field, the hockey rink, or other sporting venues. So what we did was we wanted to develop these guidelines. And so what do we do in the emergency room? Well, our first job is to diagnose a concussion. Now, knowing that many people on the call may not be healthcare providers, one of the things I'm going to talk about on the slides is, rather than use the words diagnose, we're going to use suspect or assess a potential concussion. And so one of the things in our guidelines is we've made something accessible to all of these groups. So through Corinne's great leadership and support, she's been very instrumental in moving our ability to make these guidelines go forward. So what did we do? Well, first we engaged a team of experts, because this is something that one person can't do alone. And we got a broad panel of experts to develop these guidelines. We had, the panel included the chair of actually the Zurich Concussions Conference. We had the co-founder of the Brain Injury Center from Harvard. We had the chair of the person who chaired the American Academy of Neurology concussion guidelines. We had people who developed commonly used post-concussion tools such as the ACE and the PCSI. We also included a lot of community and school-based experts, organizational stakeholders, and many others to help come up with a soup to nuts all the way to before the injury to while the child's potentially still suffering symptoms months beyond in one go-to, easy-to-access place. So how did we do this? Well, you can't. There are many things in the literature that have described ways to develop guidelines, and we used what's called the Practice Guidelines Evaluation and Adaptation Cycle. And what that does is it's a standardized way to develop guidelines. And then we wanted to make sure everything had consensus. So we chose this method, it's called the Glaser method of reaching consensus, where a lot of the members would often vote on what things needed to be or should not be included. The next step of the guidelines was to do a comprehensive literature search. So I need to throw out a great recognition to my superstar medical student who worked with me for 2 years on this by the name of Tano Pham. He went through with me, and we, after having a PhD librarian generate the search string and peer review that, we looked at over 4,000 citations to see which ones are potentially included or eligible for these guidelines. And of those 4,000, we then were able to get 400 that required a full review. So then we took our team members, our 30 team members approximately, and assigned homework, which is always challenging when you have busy professionals, but we assigned homework by taking the scope of articles and defining many themes. So some of the themes were the initial assessment, some were with the how do you manage some persistent symptoms, for example, persistent headache, how do you manage persistent cognitive problems, how do you manage the considerations for returning to school, et cetera, et cetera. And we divided these into themes and then assigned the homework out to everyone in the group. We then got together for a meeting in Ottawa in November 2013, and we worked in groups according to their expertise to draft these initial recommendations. And then once that occurred, it took several months to get them all into a uniform style, and it finally culminated in these guidelines for diagnosing and managing pediatric concussion, which came out, the first edition, for June 2014. And we prepared the guidelines in 3 versions. We had a healthcare professional version, we had the school or community sports version, and a parent or caregiver version. And we wrote it all in a uniform language such that it would be easy to go exactly where you want to go in the most efficient way as possible. So for example, one of the things we did was we included different tables and different tools to help guide parents and patients or providers, if they were the ones using the guidelines as well, to go and use that. So one of the things that I would ask patients to do if they were on the sideline, going back to our case, and wanting to assess, so let's say you're not necessarily diagnosing a concussion, if I'm asking you to potentially suspect a concussion, it's important to start off with what are the symptoms of a concussion. And so you have various different types of symptoms. So you can have somatic symptoms, and examples of somatic symptoms are things such as headache, nausea, you could be dizzy. You could have cognitive or thinking symptoms, and those might be a patient telling you that I feel like I'm in a fog, or they're having difficulty concentrating. You can have emotional symptoms where patients suddenly start crying or have emotional lability. You could have physical signs such as actually having a loss of consciousness or amnesia. And then you can have sleep problems. So the first way to suspect a concussion is to know what the symptoms potentially are. And now it's time to perform an assessment. So in our guidelines, we have these tip sheets. So I have in the webinar series here, give an example of the healthcare professional one. Knowing some of you, maybe most of you, are working in the healthcare field in some degree or some other. And the web version is an active PDF. So you could do this on the website, download the PDF, and everything that's underlined is a hyperlink. So let's say you are on the sideline and you are a trainer for this young girl, or you're the paramedic about to pick up this young girl, and you want to see if there's any physical, cognitive, or neurological deficits. What you would do is you would then click that number 2.1. And when you click that hyperlink number 2.1, it would take you to what are the things to do. And while I don't have it on a slide, I'm actually going to turn on my webcam for a moment if David could help me. And let's see, I'm not sure if it's up yet. Give me one moment. And so I just have a printed out version of our guidelines here. So you could do this on the web, or you could do it on print out the full version. So if you went to that 2.1, you would then open up your guidelines. You'd find section 2.1, and then you'd have all of the facts, such as the when, the who, the how, the why, and what the level of evidence is for this statement. So without going into too much detail, what would you do is you would take a history, and then you would consider signs and symptoms, and then you would go on to determine if any further tools are needed. So with regards to tools, I'll get to those in a moment, but let's talk about a brief history. So let's say you are at the sideline, or you're a healthcare provider. What are the things you want to find out about history? You want to find out what were the events leading up to this concussion. So what was the mechanism of the injury? Was this a motor vehicle crash, or was this something that the patient had some other type of mechanism? What was the acute event itself? Was there any loss of consciousness or changes in their ability to remember? What was occurring immediately, occurring and just afterwards? Then you're going to go through each of the symptoms. So when you look at our guideline, one of the things you would do is you would click, for example, tool 2.2 is the acute concussion evaluation, and I have a slide of that coming up in a moment. Or you could use the PCSI, which is the post-concussion symptom inventory, to see how the patient's doing with regards to how they're doing now as compared to perhaps how they were doing before. Other things that are perhaps more relevant for healthcare providers, not necessarily for trainers, but are to see are there any other factors that could help determine if there's any risk factors for having a prolonged course, such as a prior concussion, the recovery from that prior concussion, if the patient has a history of migraines or has any developmental or learning problems. Then it's also important, if this is something that you're seeing further on, get a bit of a social history, make sure that they're in a psychological good state, and to do a quick social psychological screen, the HEADS-ED is something that's very helpful, and it's a mnemonic that stands for home, education, what activities they like to do, are there any drugs or alcohol, is there any suicidality, what are their emotions like, and do they have a discharge plan? So this is an example of the PCSI, and the PCSI is a form developed by one of our team members for the guidelines, Jerry Joya, who's based out of Washington, D.C. And this is an example of the teenage form. There is similar forms for ages 5 to 7 as well as 8 to 12, and all of these are in the guidelines. And again, these are all free downloads. And for any of you in your practices, your office, you can download the PDF and then print out the version to keep copies in your office. So one of the reasons our group really liked the PCSI is that it's validated. And one of the things that we try to do with our guidelines is be as scientifically rigorous as possible. And scientific rigor for tools includes a validation process in which the questions make sense, they're answered clearly the same way, the same times by both parents and as well as by children. And the one nice thing about the PCSI is it compares to current symptoms now as compared to before the injury. So if I were to ask some of you on the call, How many of you are fatigued? Well, if you may have a young toddler at home, or you had worked overnight in the hospital the night before, you may answer, yes, I'm fatigued today. Or if you had a bit of a virus, you may have some of these other symptoms. What we're really trying to get a sense is how much is this from before the injury to now, to get a sense of how much of this may be attributable to the injury itself as compared to just how you're doing today. And that is something that this type of PCSI form is something that's also very commonly used in research, and I've used it in my own projects as well to track recovery. So now it's time to do a physical exam. And again, depending on your scope of practice, that would be something that may be more limited or more extensive based on whether the fact that you're a trainer at the sideline or if you're a neurologist. But some of the key things you want to do is just look at their ability. Are they able to walk properly? Are they unsteady? And one of the ways to check if they're unsteady is to do a balance exam. We'll be getting that into that in more detail in one moment. Again, if it's in your scope of practice, looking at the back of the eye, see if there's any signs of swelling, and then examining the full head and the neck and doing a neurologic exam. And if you want some guidance, one of the other tools that we have, again, let's say you're not sure what a neurological exam is for concussion. This is a screenshot from our guidelines listing on what some of the examples are of the neurological exam for a concussion. I'm not going to go into all those details because, again, they're all in the guidelines, and if you ever were unsure, you could go back to them. One of the things in the emergency department we really need to do is to make sure this patient doesn't have a more severe head injury. So we always look for red flags of CT. Some of the red flags are kids who coming in with a persistently low GCS scale, like they say they're 13 and they're still 13 and they're not recovering. That would be an indication to do a head CT. If a patient's continually agitated or lethargic, you find a focal neurological finding on your exam, there's signs of a basilar skull fracture, or they are actually getting worse after observation, would be potential red flags. Then there's some other things that you may want to see after a period of observation if they've improved, and if not, then consider doing a CT. So a patient who comes in with a loss of consciousness does not necessarily mean you need to CT them, and in fact, the large majority of kids who had loss of consciousness do not. It's only if they have not had their GCS return to a normal baseline several hours after that you would need to then consider the CT. If the patient had a severe mechanism, let's say they were in a car crash, they've rolled over, there's no signs of any of these other red flags, but the mechanism was very severe, you could consider a CT. And again, if the CT is negative, that meant that they did have a concussion. And that also goes the same for patients who come in persistently vomiting or come in with severe headache. If those symptoms resolve, then no CT is needed. But if they continue to persist several hours afterwards, that would perhaps indicate a reason to do a CT scan. So now it's time to do a little game. So one of the things that you're gonna do is to check some cognition. So we're going to evaluate your ability to concentrate. So one of the things that can be often performed in the clinic setting or in the emergency setting is to see how immediate memory is by, for example, giving a list of 5 words. And these are on the screen. You can see an example: elbow, apple, carpet, saddle, bubble would be some potential examples. One of the more fun things to do is a digit span. And as a pediatrician, you always have to speak on the patient's level. And so what I tell my kids when I do this is we're going to do some brain games. And we're going to see how well your brain's thinking. So I'm going to give you some numbers, and you're going to read them back to me in the reverse order. So for example, if my patient is a 10-year-old, I'm going to say, okay, Johnny, I'm going to give you the 2 numbers, and then you're going to listen to them, and then read it back to me the other way. So for example, if I said to you 7, 1, you would answer 1, 7. And if they get that one correct, you move to the next longer span. If they make a mistake, you repeat the same span. If they get it correct, you move to the next. If a patient gets 2 mistakes in a row, they get the 4-digit span incorrect the first try and the 4-digit span incorrect the second, you stop there knowing that they only made it to a digit span of 3. So I thought I would test the group by giving you a 5-digit span test. So I'm going to read the numbers to all of you. Try not to look at what other people put in for their answers, but and don't type them immediately because that's cheating as well. Think of it in your head, and then normally you would read them back to me, but I'm going to read you the span, and then you see if you can get the numbers in reverse order. The key when you do this in practice is to read the numbers slowly, clearly, and about one every just under a second. So I'm going to go ahead and give you a 5-digit span. I want you to think, and then type your answer into your voting box of what the reverse of that is. So here goes. Here comes a 5-digit numbers. I want you to read, or in this case, type them back to me in reverse order. 4, 1, 3, 8, 5. Everyone now go into your little voting box and see if you can do it. So most of you are able to get them right, and I'm sure there's some not a purely scientific method. There's obviously going to be some biases here because you can see this. But for those who had gotten it incorrect, what you would do is you'd repeat it again a second time. So this is just something very simple. There's no magic list of numbers that you must use. You can make up your own list of numbers. Try not to repeat any 2 numbers in the list, but as long as the numbers are different from each other, you can pick any examples of numbers, and we only typically go up to a maximum of 6. And if you can get to a maximum of 6, you're doing very well. So that's how you can briefly assess memory, and it's sometimes very impressive to think a kid may look fine in front of you, but when you test this, you may see that their memory is not as good as you thought. So now it's time again to, I'm going to turn on the video camera again, and we're going to talk about balance now. When we evaluate balance, it is something that is many of us typically don't always do, but the evidence is showing that we should be doing balance testing. So in the slides here, you can see some examples of what's called this BESS, and BESS stands for Balance Error Scoring System, and it's a standardized, validated way to see how patients function with their balance. As you can see, in the example, the patient is barefooted. You want to be able to not have, for example, high-heeled shoes, because that will make your balance worse. If you are wearing a hiking boot or a basketball shoe with a high ankle support, that would actually improve your balance. So that's why we say barefoot is the best. So everyone's going to kind of stand up at your desk if you are able to, or stand up in your office, and we're all going to try this together. With the webcam, I'm unable to get my feet in the screen at the same time, but you can see how the feet are. For the first test, which is called double leg, your feet are truly together. So it's heel to heels, toes to toes, lining up straight, and your knees just have a very slight bend to them, and your hands would be on your hips. And then the next step would be to close your eyes. These tests last for about 30 seconds. So everyone's going to put their hands on their hips, stand still, and we will do this for 20 seconds just as an example. And then I'll talk about that when that occurs, what the errors are. In fact, I'll actually go over the errors first. So examples of errors are if when you're in your position, you take your hand off your hip, that would be an error. If you end up opening your eyes, that would be an error. If you take a step forward, that would be an error. So those are examples of errors. Now let's say a patient, and this commonly occurs, takes a step forward, they open their eyes, they take their hands off their hips. That's not 3 or 4 different errors. It's all in one event. So what you would do is just instruct them at the beginning that if they make an error, don't worry, just get back into position as quickly as they can. So if they had their error, but then got back in, that's just one. If they had their error, but can't get back in, or they can't even close their eyes again and they're still too unsteady, then they have failed the test and they get the maximum error points. So I'm going to start my watch. Everyone's going to go for 20 seconds and they're going to do their balance of both legs together. On the count of 3, 2, 1, go. And this is the position that most people can do without any concerns. That's 10 seconds. And 20. So now we're going to do the harder test. What I often then tell patients to do, this is for the tandem error testing, what you typically want to do is you want to determine if they're, rather than just right-handed or left-handed, you want to determine their footedness. So the way you do that is say, pretend there's a soccer ball in front of you and give it a kick. And it's the leg that does the kicking is the leg that should be in front. So you can see in the slide example, the young man is right-footed because his right foot is in front of his left. And again, you want to be barefoot. Your right foot, if you're right-footed, in front of your left, and in a straight line. It's as though the Ontario Provincial Police are suspected that you had too many beers at your Christmas party and having you walk the line on the road. So you're going to be pretending to walk this line. And now again, you're getting in that position, you're putting your hands on the hips, and now you again are going to close your eyes. And on the count of 3, we're going to do that again. All right, everyone in their tandem position. 3, 2, 1, go for 20 seconds. We're going to see how you all do for the tandem gait stance, or the tandem stance. So that's 10 seconds. And 3, 2, 1, good. So, why doesn't everyone take a seat back down? Did anyone find that, you don't have to disclose your name if you want, but it's often found that some people find this more challenging than some of the other types of tests. So, the reason I also shared this with you is that something that our research has actually shown that doing the tandem stance is something that the tandem stance is something that actually helps predict duration of symptoms. But that's research that I will hopefully be sharing with you another time, not in the scope of the talk today. So now you've assessed the patient, you've determined that they have a concussion, or let's say you're the person on the sideline, you suspected they had a concussion and you send them now to the emergency department. It's now time to send them home. And here's an example of these important examples of how to discharge patients, on what to tell them and what to tell the caregivers. And if you look, there's a whole list of examples of given examples of written handouts in addition to just giving verbal information. Really go over the recovery period and how to return to both learning and returning to playing. And I want to go into those in a bit more depth. One thing I also wanted to point out is the level of evidence. As you could see, we got a lot, 1A and mostly B's and C's. If this was a report card I brought home to my mom, I know she wouldn't be too happy with that. And I think as researchers and scientists, it's something that we shouldn't be too satisfied with either. To get level A evidence, you need to have numerous studies of good nature, or one very large multi-center study done very well, in which the answer is now conclusive. And we are not at that point yet for many of the recommendations that we need to send patients home with for concussion. And it's for that reason I say that we're still at the tip of the iceberg on what are the expected course of recovery, what is the evidence on return to learn, what is the evidence on return to play. There's still B-level evidence at best, which is based only on several small studies. Whereas level evidence C, to give an example, is expert opinion only. So we still have a lot of work to do as scientists to get all these B's to turn into A's and to get these C's turned into A's or B's. So that's a plug for those of you who are interested in research or advocating for research, that these things really have to continue to progress. So what are the key information? Again, talk about what needs to be done and go over it in a written form as well. Go over what the steps are to return to school and return to play. Go over the risks and complications of re-injury, and I have already alluded to that at the beginning of my talk. Making sure that patients really rest and recover, so that really means good sleep as well. And make sure that their symptoms are being treated. If a patient's having headache, they shouldn't be afraid to take headache medications. And our guidelines go over which medicines we recommend using various algorithms as well. It's important that they still keep their social interactions. So although this child may be out of their sports teams for a little while, or perhaps even doing just shortened days at school, they don't lose their friends and lose the things that are important to them. Even things that you would think would be good ways to keep up their interaction, like going to a movie together on a Friday night, may actually be too difficult for this concussed teen, because the loud noise and the relatively bright lights of the screen may really trigger worsening symptoms. It's important they avoid any drugs or alcohol. They do not drive if they're still symptomatic, and they need to still have good follow-up with either their primary care provider or even at specialized care if the symptoms are worsening or persisting beyond 1 month. So what are the treatments? Well, there's going to be physical cognitive rest, which I'll go over in a moment. You want to treat their symptoms, such as their headache. You want to, again, make sure they stay hydrated. And things like earplugs or even noise-canceling headphones can be helpful for those sensitive to noise, and sunglasses can help for those sensitive to light. I'm sure many of you on this webinar are very familiar with these stepwise return to play guidelines. Typically, the recommendations say no activity is necessary and complete rest is required before the first step of light aerobic exercise should be done, and then the steps progress with a minimum of 24 hours between each step. These are based on the Zurich recommendations. It's something I'll go into a bit more in a moment, but this is the safest way to prevent a re-injury in the recovery period. However, it's still controversial on what is the ideal period of rest between step 1 and step 2. Much of things in life are like Goldilocks. The porridge can't be too hot, the porridge can't be too cold, the porridge needs to be just right. I'm afraid as a scientist, we let the pendulum swing too much sometimes to one way or the other. Years ago, we swung the pendulum to go back immediately, you're fine. That didn't work out so well. We are now, I think, at the other end of the pendulum, where we see in this day and era, people are sitting in dark rooms for weeks on end, months on end, not even going for a walk outside, not even getting their heart rate up in the littlest bit. And that too may actually lead to signs of depression, social isolation as well. And what we need to do as scientists is help determine what's the just right. But to go into this is what the current recommendations state, is that, again, you need to limit school, work, and tasks requiring concentration and refraining from activity until symptoms are gone. And then when they're gone, your physician will clear you to move to the next step. The next step will be activities such as walking, stationary cycling, not regular cycling, stationary, because you don't want to fall if your balance is off, and you don't want to be at speed and risk a new injury. But again, you need to be supervised for this. This next step is going to be skating or game-specific tasks, but no contact. The fourth step is full drills, but without contact. And then you again need medical clearance to resume contact, and again medical clearance to go back to full gameplay. These are done very well by our partners. There's many examples of handouts. We felt that the parachute guidelines, handouts were quite excellent, and they are included in our guidelines as one of the tools in our appendices. The return to school, again, has two examples in our guidelines on examples of how to return to school. Again, no school perhaps for a couple of days of class, and then after 48 hours, patients can return to school for a partial day, with no tests or homework and minimal expectations. The next step would be to attend most classes with some breaks, but again, no test and minimal homework. And these will progress through the stepwise continuum till the patient's at full class schedule and back to full expectations for their productivity. This, as you can imagine, is something that really requires excellent communication between the healthcare provider, the patient, and the school, and the family. And so this is something that in our guidelines, not only did we include examples of how the patient could return to school and how to return to learn, but examples of handouts that could be used to communicate from the teacher back to the patient and the doctor and vice versa. What are these kids able to do? We've included in our guidelines some examples of active suggestions for what the kids can do for recoveries based on their age groups. And again, as I alluded to earlier, it's important to get rest, but I think this newer evidence that has come out subsequent to the development of our guidelines is showing that too much rest is perhaps even a bit harmful, and that's our job, is to determine the just right. And that leads me to the last thing, is as you may notice, our guidelines say version 1. Corinne and the rest of the ONF team have been incredibly supportive in ensuring that these guidelines are updated, and we will have a version 2. And our version 2 will incorporate many of the new evidence that we find out over the subsequent years from when these developed guidelines were published to what newer has been determined, and hopefully we'll be able to update the next version with what the changes are. So let's go back to our case just to wrap up. Our young patient was assessed. She had 5 symptoms on her symptom inventory. She did have some difficulties with concentrating, but the balance exam, the neck exam, and her coordination was normal. She did not need a CT. She was given recommendations for physical rest by using the parachute return to play, and she was given the ACE return to school. And over the subsequent 3 weeks, she fully recovered and was back to full activity by that point. So with that, I wanted to just provide everyone with some additional resources. Again, the ONF website hosts the concussion guidelines, and they are a free download. Again, the parent version, the school and coach version, and the healthcare provider. I've collaborated as well with other concussion experts and with Dr. Mike Evans, who does these great YouTube videos. And there's a great video that summarizes much of which I talked about on how to return to learn on one of those whiteboard interactive illustration videos, as well as some additional resources. And with that, I'd like to thank all of you for your attention, and I'd love to take some questions if anyone has any questions for me.
If anyone has any questions, if they could just type them in the chat and I'll read them out. Thanks so much, Roger. Great presentation.
Thank you. I also see that, I'm not sure if Corinne just put it up, but it's reminded me that we also now have a French version that's going to soon be released. The INES, which is the organization in Quebec that oversees the guidelines for various types of common ailments, and particularly invested in head injuries, has spent several months going through our guidelines and ensuring that all the tools are translated perfectly, and that is now done and will soon be ready for distribution. So that's something we're very excited about. And again, I will be hosted, I imagine, on the ONF website as well. Thank you, Phil, and I will see you tomorrow. For those of you on the call, there's a great conference that Phil and Nick Reed are co-hosting along with some others. It's called the One Voice Concussion. It's taking place in Toronto, and I'm very excited to be part of that great project that's about to embark.
Drew would like to know, what role does the cervical spine play in concussive symptoms, in your opinion?
So it's a great question, Drew, and I think one that we need more research on. But the fact that the cervical spine actually plays a very large role in concussion symptoms for the following reasons. So number one thing that we've observed in my research is that, and others as well, is that girls suffer symptoms. They have a higher risk of having prolonged symptoms than boys. So one of the thoughts is that the neck may play a key role in that. One example is that many boys may have a more muscular and a stronger neck than girls, and thus while boys playing soccer very rarely suffer concussion at the same rates, girls playing soccer suffer concussions at much higher rates. And that may be due to the fact that their neck musculature is not quite as developed as boys. There's many hypotheses as well as to why these differences may exist, but the thought is that there may be some elements of the cervical spine to that. Further, there is vestibular effects due to the injury, which again are neck related. The more spinning and rotating of the neck, you can have vestibular symptoms, and there are many experts. There's a group out in Calgary, Catherine Schneider being one of them, who are really developing an expertise in therapies following neck manipulation for the types of balance and dizziness issues that they have to realign the semicircular canals in the middle ear that can be affected following concussion. Further, there is a lot of controversy. I know Sidney Crosby mentioned that in the end it was a neck issue. That's always tricky, and I don't know the details of the case to say exactly, but I think if you ask most people, again, the majority of the symptoms are due to a neuron on the brain, but like all things in life, there are always many things can be injured, not just one.
Do we have any other questions?
Again, speaking anecdotally, Drew, I know to answer your questions, particularly the atlantoaxial, the C1, C2, this is something that we had about 3,000 kids enrolled in our study. There were many kids of those who did have cervical spine imaging, not thousands obviously, but there were still several dozen, and there were very few noticeable changes on imaging on those kids. I think we only had to eliminate or exclude a very, very few kids on the study because of the fact that their primary injury was to their neck rather than to their head. But again, I think it's an important point to always consider the neck, and it's an important part of the exam, because if you suspect a neck injury, the management may be very different. They may need orthopedic follow-up or neurosurgical follow-up. They may need to go home on a cervical collar, and the rest and return to physical activity recommendations may be very different depending on the nature. So I see Corinne just said, can I tell a little bit about the 5P study? I'd be happy to. So the 5P, as Corinne gave the acronym, Predicting Persistent Post-Concussive Problems in Pediatrics. It's the largest pediatric cohort study to date. We enrolled over 2,000 kids in a derivation phase and an additional over 1,000 kids in a validation phase, in which we prospectively enrolled children across 9 centers across Canada to determine what are the factors that predict how long children will have their symptoms persist for following their concussion. Based on a systematic review we had done earlier, it was very hard to determine which children would recover quickly and which ones would take longer to recover. And our study has looked at those factors, and over the last 2-3 years, we've been able to come up with a list of factors that are more specific in predicting with better sensitivity and specificity than doctors are without the tool on that. We did publish our abstract at the recent Pediatric Academic Society, and that's something that we're in the process of doing the full analysis of the validation, and then we'll be submitting hopefully this summer for full publication at a general medical journal for broad spread knowledge translation to help doctors have a better sense of giving parents the advice. Because right now when patients come in, doctors are not very good at knowing if their patient in front of them is going to get better in 2 weeks or if they're going to take a month or more to get better. And hopefully with this 5P rule, again, that will be soon ready for prime time this summer, we'll be able to better predict that.
So we have another question. A. Barry would like to know, do you foresee contact sports like football being limited or even removed from elementary and secondary schools?
So it's a great question. I think the group out in, there's a sports group out led by Carolyn Emery and Winna Miyawis has been doing some really great work in looking at the checking age in hockey and seeing if that's had any effect on concussion rates. And I don't think that study is published yet, and I don't want to quote anyone else's work, but based on some just informal conversations I've had with that group, it appears as though those results are very optimistic in that some basic rule changes can really lead to reduction in the amount of injuries that we see with new concussions. So do I foresee contact sports being removed? As a former athlete, I'm still an athlete myself. I've chosen to move away from contact sports, and I typically do endurance sports such as running or triathlon. But as a former collegiate athlete, I do really understand and appreciate the benefits of team sports. I appreciate the physical benefits of being healthy, of living a healthy, active lifestyle. Given the obesity epidemic in our North American society, I think it's important we do steps to prevent unhealthy and inactive living. So I do want to make sure that we still have opportunities for sports. That being said, I think it's within each sports regulatory body to start looking at what does the data show on, are there simple rule changes that can be made to reduce the risk of injuries. So for example, you asked me as a parent, I have twins, I have a son and a daughter. They both played soccer and they both play hockey. Now at their current ages, which is 8, hockey is still non-contact, and soccer there's not much heading, and they're not teaching currently a lot of heading in at age 8. So the question will remain is, what do we do when my kids get to 13, 14 and are now in the ages where they do have the contact? I guess I'll have to see what the evidence says and work as a parent and as a scientist at the same time and make the best decisions for my kids. To speak as a general rule, I think it's something that we need to best do the evidence to show that these things do make a difference before we make broad generalizations that sports need to be eliminated. Now, if I can put a plug in, I think sports like boxing or mixed martial arts that you see on the extreme sports where the whole goal is to knock out your opponent, I absolutely can say those sports should be banned for children, given the fact that the whole purpose is to inflict a concussion on the other person. I see another question. Should every child suspected have a concussion be seen in the ED? Again, a very good question, Carol. I think one of the things in the guidelines is we provide that pocket recognition card on the sideline to give a sense of what kids may have red flags. So the key take home is if a concussion is suspected, they should be removed from whatever activity may cause a future injury or a second injury. So if this is at a school and the child fell off the playground, have them sit down, have them perhaps even be picked up by their parents, and should not be going back to the playground, should not go to gym later that day. If they're feeling their symptoms are improving, they may not necessarily need to go straight to the emergency department, but they probably should be followed up by a family health team member, such as a family doctor, a general pediatrician, or a nurse practitioner, whatever sort of setup that primary provider is for that family. I think the emergency cases, those in which we need to consider whether a CT is needed, those must go to emergency. So in short, do all cases have to go to emergency? No. Should all cases be seen by a healthcare provider? Yes. And it is important that does occur to make sure there's good communication, good follow-up. We also know that concussion symptoms can, we say, wax and wane. So they can start high, they can start to improve, but as the symptoms go on, they can come back up again. So it's a waxing and waning with the strain that the brain is currently experiencing.
Any last questions? All right, so it looks like that's it. Thank you so much, Roger.
It was my pleasure.
And we'll see everyone again in 2 weeks for our next webinar with Robin Green. Thank you very much.
Thank you, everyone. Have a good day.